Honorable Chairpersons and learned audience, good afternoon. I am Dr. Mohammad Ahsanul Abedin, working as an assistant professor in the Department of Surgery, Chittagong Medical College. My topic of discussion is intraoperative practice, impact of intraoperative practices on specimen quality in surgical management of the colon cancer. I have nothing to disclose. Global burden of colon cancer is rising alarmingly, about 1.8 million new cases per year. Most of them are candidate for upfront surgery. But the quality of colon cancer surgery influences the patient survival, especially in stage 3 disease. How can we assess the quality of the surgery? Resected specimen is the testament of radicality of colon cancer surgery. But we are not concerned about the specimen quality. How can we assess the completeness of complete mesocolic excision? There is a variability of intraoperative practices among the surgeon, and its impact on specimen quality remain an area of concern. And there are some indicators of specimen quality which are influenced greatly by the intraoperative practices. And in our practice, there is lack of check of surgical specimen quality. Poor quality specimen leads to pathological staging inaccuracy, and there is likelihood of stage 3 diagnosis. There are two terms. Mesorectal excision, it is already well established. But complete mesorectal excision, there is still lacking of evidence of some randomized control trial. Embryological tissue not only covered mesorectum, but it also covered the whole of the colon. So CME is translated from TME. What do we mean by complete mesocolic excision? There is sharp dissection of the visceral plane, origin of the colonic arteries should be well exposed and tight centrally. Lymph node dissection is very important in colon cancer surgery. Most of the lymph nodes in the central artery, around the central artery, have more metastatic potentials. And these are some figures of level of lymphadenectomy in right colon cancer, in left colon cancer. Another thing is important, that is the length of bowel resection, how we can determine it. Is it only the length from the tumor? According to the Japanese Colorectal Cancer Society, the feeding artery identification is very important, intraoperatively as well as in the specimen. And according to the feeding artery distribution, they classify the colon cancer into 4 types. In the type 4 cases, the length of the bowel resection should be more than that of the type 1 cases. And pathologists should also remark in their report about the metastatic potentials of lymph nodes according to the lymph node subgroup. So our study is performed as because specimen quality is not conventionally considered as a prognostic factors, and there is no standardization of the intraoperative technique in colon excision, and surgical specimen quality is yet to be established in our country. This is a retrospective study, and prospective data was collected from electronic database, and it is conducted in the Chittagong Medical College. We include the histopathological proven colon cancer, BMI less than 30. We exclude recurrent and emergency cases of colon cancer, and coexisting inflammatory disease is excluded as there is difficulties in mesocolic plane integrity. And inadequate postoperative histopathological report are also excluded from our study. How we can assess the specimen quality? There are some parameters. That is, here the A is marked by the tumor to high ligation distance, B closest bowel wall to high vascular tie distance, and C is the whole bowel length, and the area of the mesocolon is multiplication of A and B. Lymph node number retrieval is also assessed by the pathologist. This is also a specimen quality. And mesocolic plane integrity assessed both by the surgeon as well as the pathologist. 3 types of mesocolic plane integrity. If the mesocolon is intact and breach less than 5 millimeter, it is type A, that is we go through the mesocolic plane. If it is more than 5 millimeter, then we go through the, then it is intramesocolic plane, and type C is the ragged. Bench classification is a new classification system for right hemicolectomy specimen assessment. In bench type O, this is the best quality specimen. In bench type 1 and 2, the mesocolic window is deficient. And in bench type 3, this is the poor quality specimen. Here is some of our operative pictures, video. We are going through the mesocolic plane. Here, the central vessels are ligated near the superior mesenteric vessels. And for D3 lymphadenectomy, we are dissecting at the medial part of the superior mesenteric vessels. And after removal of the specimen, this is the perioperative view. Here, the vessels are exposed. This is the photo documentation of some of our specimen. So what is our result? Most of our cases are, we do the CME, that is complete mesocolic excision. 38 cases are complete mesocolic excision. And according to the tumor location, most of our cases are from ascending colon tumor, although it is contrary to the international data, as most of the colorectal cancer located in the left colon. But in our study, this is in the ascending colon. Lymph node retrieval technique, CME and CVL, we retrieve by D2 lymphadenectomy, and non-CME cases we retrieve by D1 lymphadenectomy. This is the specimen quality morphometry for CME. We collect data at the number of lymph node retrieved, distance from tumor to high ligation, shortest distance from bowel to vascular tie, mesocolic area, distance from tumor to proximal margins, and distance from tumor to distal margins. And in the non-CME, the data shows like that. But we do a statistical analysis of both these data, and in case of CME, all the parameters are significantly higher than that of the non-CME. Regarding mesocolic plane integrity, 71% cases, mesocolic plane are intact in CME, whereas in non-CME, 45% cases it is intact. There is discordance between the clinical TNM and pathological TNM. In case of CME, there are 29% case, there is upstaging in the pathological TNM. But in non-CME cases, 46% case, there is downstaging in pathological TNM. According to the bench classification of our right hemicolectomy cases, most of our cases are type 1 and type 2. Our study results corresponds to other study results, but there is the difference about the distance from tumor to vascular tie and mesenteric area. And this may be due to variation in the ethnicity as well as the measurement technique. And stamped length of the resected central artery is a strong predictor of radicability. That is, the central vessel ligation can be assessed by postoperative CT angiogram. Here the stump length of ileocolic artery and middle colic artery is assessed. So in conclusion, we can say that CME with CVL significantly improved the specimen quality in colon cancer surgery, leading to better staging accuracy. And specimen quality can be considered as a prognostic indicator of oncological outcome of colon cancer. Standardization of the intraoperative practice by multi-center studies to get a good quality surgical specimen will enhance the patient outcome. We have some recommendation from our study. Indicator of specimen quality should be mentioned in the OT note. Photo documentation of fresh specimen must be supplied to histopathologist. And histopathologist should give feedback to surgeon about the specimen quality, that means the quality of the surgery in the postoperative MDT for better patient outcome. Thank you all for patience hearing.